There we go.
Excellent.
Awesome.
I think we figured out all the technology. Thanks for bearing with us. Yeah, appreciate it. So just to do a bit of an introduction kickoff, we're really fortunate to have some of our great community partners at Wellmore who we've been fortunate as United Way been able to partner with for many years, not only by providing financial resources, but working together in our community to advance some of our work around behavioral health and substance use disorder, as well as homelessness and a whole host of other things throughout the decade plus long relationship that we've had with Wellmore. So we're really grateful for spending the time with Wellmore and having conversations with their CEO, Gary Steck. We had learned some things during our needs assessment as we've been able to kick off our 3-year funding cycle, which we're really excited about to share with folks the next few weeks. And one of the emerging themes that we learned from Gary and the Wellmore team is the ongoing crisis around alcoholism in the community. And we thought it would be a really great opportunity for them to shed some light on some of the things that they're seeing and experiencing in their services at Wellmore, and how that has a real direct impact and effect on the greater Waterbury area, which they serve. And then some. Wellmore is quite large, as most folks know. So really grateful for Regan's leadership and Dr. Young for your expertise here as well, to spend some time with us on this important topic and to start to raise awareness so we can do together as a community to help support some of those in our community. So kick it off to our friends at Wellmore. Thank you.
Thank you, everybody, for signing on, and thank you for being interested in this topic. We talk about this all the time. It's our everyday life here at Wellmore and Adult Services. So we're excited to share it and excited to hopefully pass along some information that we think is interesting, so we can help others and help our community. So we have a plan today to go over the trends that are going on that we're seeing. Data to reflect that. Dr. Young will go into alcohol use disorder in a little bit more detail, and then I'll talk about some of the treatment options and what Connecticut's doing to try and help support this crisis that we're having right now. So I don't know if Doctor, do you want me to share my screen and do the slides?
Yeah, let me see if I can try.
Okay.
Do you guys see the slides at all?
No.
Let me see. How about?
There we go.
Oh, you're seeing it now?
Yep. Perfect.
Okay, great, excellent. Okay. Yes, again, thank you so much for having us, and particularly excited about. It sounds weird to talk about alcohol, just because, as you're kind of alluding to earlier, we've spent so much focus on fentanyl and now this combination of fentanyl and xylazine, and the overdose epidemic has been pretty intense, the opioid epidemic, and actually there's some slight bright spots there, because it does seem like in a lot of areas that is starting to turn a little bit. So keeping an eye on that. But alcohol has a very, very long arc. There's a long narrative here that goes back a very long time. And I am going to spend a little bit of time on the history, a little bit of time on the epidemiology, the numbers, and then 4 trends that we're seeing before I mention some of the FDA-approved medicines, and hand it back over to Regan to talk about regional issues, level of care, and other psychosocial interventions. So now I'm trying to, let's see. Okay, so this is not a spelling bee, because I can't spell these 2 words, but I picked these 2 words because, first of all, I didn't know what they meant, but more importantly, I think they're very important today, and to use a fancy word, prescient in terms of their meaning. So the zeitgeist is the spirit of the time, the general trend of thought, feeling, or taste characteristic of a particular period of time. So this is really interesting, especially in this long history of alcohol through civilization. And the feeling of the times is very different after a pandemic than it was, say, 20 years ago, or than it was 100 years ago during Prohibition in the 1920s. And so I think that's an important term that will have context here in our talk today. And then perspicacious is a word that means having a ready insight into and an understanding of things with balance, really. And I think that what's really powerful today is that there's just so much bits of information and data coming at us, whether it's social media and Facebook or TikTok, or whether it's CNN or Fox News or wherever. And the thing is that with all that information, we automatically put up filters, and whether we tend to get our social media in a certain way or through certain news organizations, those filters get really controlled for us. And so sometimes we don't get that balance. We don't have that sort of good insight into things. And we saw this tragically impair our public health system and its messaging, which led to thousands and thousands of deaths, unfortunately, during the pandemic. So moving on to history, I think what's really important to understand is that alcohol is one of the oldest psychoactive substances, maybe up there with caffeine. And consumption really predates recorded written records. So you can go back 7, 8 centuries to Middle East records where first were being kept, or in China 7 centuries ago, and they're already talking about alcohol at that point. In the book of Genesis 9:21, after the flood, Noah plants a vineyard, makes wine, and gets drunken. And I think that, you can certainly understand trying to get 2 of every species onto a boat in the middle of a massive rainstorm. Yes, I get it. He needed a glass of wine afterwards. But even references so far back into literature, we move forward many, many years to 1784, and Dr. Benjamin Rush, one of the signers of our Declaration of Independence, identifies alcoholism as a disease. And this is really critical because we've lost that sense of alcoholism as a disease over the last 100 years, and it's been very much stigmatized. And we'll talk a little bit about how we refer to it in a clinic that deals with substance use disorders. We move forward to 1920. For about 10, 13 years or so, Prohibition was enacted in the 18th Amendment. And then in 1935, the founding of Alcoholics Anonymous. In 1960, Ian Jelinek described the gamma subtype of drinking, and this is most notable for loss of control, the inability to stop after 1 or 2 in a really intense way. So to pivot from history to the numbers, alcohol, the numbers, and the scope of the problem. In the past year in our country, close to 177 million people drink alcohol. So this is almost 2/3 of our population over the age of 12. The DSM-5, which is our Diagnostic Statistic Manual, 5th edition, is what counselors, clinicians, doctors, addiction specialists use categorically to diagnose use disorders, mental health disorders, and we use it to diagnose a substance use disorder, namely alcohol use disorder. You'll notice that throughout the talk we'll refer to it as AUD, or alcohol use disorder. And this is really done, there's been a huge pivot over the last several years to really move away from using terminology like alcoholic or alky or alcohol abuser, things like that, because of the propagation of stigma. Those terms can be very stigmatizing and lead to individuals who are afraid to get care or feel very isolated, and pushes them back into isolation. And here in the tradition of Dr. Benjamin Rush, we are trying to make it more objective in our understanding of this disease. So in the U.S., alcohol use disorder is affecting close to 30 million people. That's about 11% of the population, which is pretty significant, obviously. Things to look at are deaths involving alcohol are increasing. The average estimated annual deaths from excessive alcohol use have increased 30% since before the pandemic to midway through the pandemic. Alcohol-related traffic fatalities have increased 14% in 2021, which was the highest recorded since 2007. And keeping in mind that safety features and vehicles have been dramatically improving every 5 years or so. So this is a pretty staggering number. Also, I think important is that alcohol is listed in 1 in 6, or 16% of all drug overdose deaths in 2020 and 2021. And that's important because alcohol is a central nervous system depressant, which is similar to an opioid, which is also a central nervous system depressant. So one of the things that gets us really concerned is when someone is using both, because they're at a very heightened risk of overdose when you're combining two substances that cause sedation. So here's a graph, and if you look on the bottom, the x-axis, this is the years starting in about 2000 up until 2022. And on the right, on the y-axis on the left will be death certificates listing alcohol as a factor. And this has nearly tripled since 2000. You'll see that one dot that's got a red line around it. That was really in the first year of the pandemic. You see a huge jump in death certificates listing alcohol as a factor. So getting back to the diagnosis, how do we diagnose alcohol use disorder to give us a sense? So the DSM-5 uses really these 4 categories to monitor and understand any kind of substance use disorder, whether it's cocaine or alcohol or tobacco or even cannabis. These are things that there's probably about 11 or 12 symptoms, and they start with someone's impaired control, the level of social impairment that the substance use is occurring, risky use, is the person using the substance in a risky fashion, and or pharmacological or physiological dependence. And if you have 1 or 2 of these across these 4 domains, that might be considered mild. If you have a couple of them, it might be considered mild alcohol use disorder. If not, if you have more, 4 or so, that would be moderate, and then significantly more would be severe alcohol use disorder. So let's just take a quick look at some of these things. Impaired control. Someone's using larger amounts over longer periods of time than originally intended. There's a desire to cut down and or an unsuccessful attempts to cut down. A great deal of time is spent using or recovering from the effects of using. And then there's this intense desire to use or craving. And I remember, I don't know if I was in college or high school, but something that really stuck with me was, it was either a celebrity or a politician's spouse who was in recovery, was discovered to be trying to drink either hand sanitizer or something, and it just struck me as how powerful this disease would be for people to do stuff like that. And so that really kind of piqued my interest in sort of biology and how I got into sort of learning more about addiction medicine. Social impairment. someone gives up social, occupational, or recreational activities, using causes and exacerbating interpersonal problems, or they fail to fulfill obligations at work or school or home. So any of one of these can be, begin to be problematic and concern if someone vulnerable for alcohol use disorder. Risky use, this would be done like obviously driving under the influence, or continued use despite negative physical or psychological consequences. And then this last bar is really pharmacologic, which I really refer to as physiologic dependence. And this is where tolerance has developed. I need 4 beers to feel the same as 1 beer used to cause, or I develop withdrawal symptoms if I stop drinking. And we'll maybe talk a little bit more about that as we kind of get into levels of care and things like that. Okay. These are the 4 kind of topics I wanted to talk about today, because I think there's there's a movement here in the story of alcohol in our society. So the scope of the problem, the trends in alcohol misuse and consequences. And there's one bright spot here, and that may be the top one, adolescent alcohol use. But this is a huge story, which I want to spend a little time on, as women and alcohol, older adults and alcohol, and then the effect of the COVID-19 pandemic on alcohol use and its consequences. So in this slide, got a couple busy slides, but we can just work our way through them. And this is a trend downward. So you see years across the bottom from 2003 all the way down to 2022. And then past month usage is the y-axis, how much is being used, what percentage are using alcohol in our age group of 12 to 20. So this is adolescents. And alcohol use and binge drinking are declining. So this is actually good. Hopefully it's not because of cannabis, but it certainly is on the decline pretty significantly for both females and for males. Although there's a story here that's a little concerning, and that is that it is declining, it's seemingly less for females than for males. Males are faster in terms of the declines in usage. And that in the binge drinking one, you see that actually females have now surpassed males in the adolescent age group for binge drinking. So we follow this. This is I think, hopefully this is the busiest slide. But on the left hand, let's just focus on that for a second. For adolescents and young adults, alcohol use is decreasing, but faster for males than for females. If you look at young adults, kind of mid-20s and late 20s, alcohol use is actually increasing, but faster for females than males. And for middle adults, alcohol use is increasing as well for females, but not for males. And then for older adults, alcohol is increasing across the board, but more in females than males. The 2 graphs really just show the converging, if the males are the yellow dots and the females are the white dots. And historically, males have always drunk more, have always had more morbidity from alcohol. But what is worrying a lot of researchers who follow this is this convergence in how women are using as much and even surpassing in some categories the amount of alcohol use. So at the bottom, in our older adults, past month alcohol use among people is actually getting closer and closer than it was. So moves us on to alcohol and women's health. We just talked about how it's increasing more in women than in men. And over the past 100 years, gaps between men and women have narrowed in both the prevalence of alcohol use, total amount drunk, binge drinking, early onset, and alcohol use disorder, as well as DUIs, have all been narrowing between men and women. In the last decade, alcohol use disorder has increased significantly for all people. In men, it's gone up 35%, but the big story here is that it's increased 84% in women. Alcohol and women's health. What's really remarkable to me is that over the last 10 years, and I don't have a slide on this, but I'd love to put one together, there has been an enormous amount of cultural marketing towards women and alcohol use. I don't know if anyone's familiar with some of the social media groups on either Facebook or TikTok, Snapchat, I don't know, but wine women, or there's these different groups that are really focused on women and drinking, especially young women. And alcohol is not just about being careful when you drink. It actually affects multiple organ systems. So studies suggest that women are more likely than men to experience a variety of alcohol-related harms at comparable doses. So one drink of alcohol has a higher concentration in a woman than one drink of alcohol in a man. We'll talk a little bit more about that. But the symptoms that are more characteristic and that happen more easily in women are hangovers, blackouts, liver disease accelerates more quickly, brain atrophy, cognitive deficits, cardiomyopathies. So cardiomyopathies are when alcohol affects the heart. You may have seen advertisements on television for medicines for something called atrial fibrillation. And it can be caused by many things, and other cardiomyopathies can be caused by viruses or many things. But alcohol is also a big cause of atrial fibrillation, which is an arrhythmia that affects the heart, and cardiomyopathy, which is when our powerful constricting heart muscle gets loose and flaccid and is not as efficient at pushing blood around the body to the lungs, into the heart, and to other organs. And that can cause deadly consequences. And those cardiomyopathies can happen from chronic alcohol use. There's also a faster progression from first drink to alcohol use disorder diagnosis in women. And then certain cancers are more common in women who use chronically use alcohol. Larger increases in alcohol-related ED visits and in hospitalizations affecting women. So why is this? What is the biology going on here? And I'm not going to get into biochemistry too much other than to make some generalized labels to sort of identify three main areas, the different colors here. One is body composition. So women's body mass is lower in water and greater in fat typically. And so what that means for alcohol is that alcohol and fat don't get along. Alcohol doesn't get absorbed into fat typically. What happens is it gets pushed out into the other fluids, blood and other tissues in the body. And with that, you have higher blood alcohol concentrations because the fat's not absorbing it, and there's lower water to deal with, so the concentration of alcohol in that water is actually higher in the body. Then there's two enzymes. One is stomach alcohol dehydrogenase. This is an enzyme in the stomach, and women have less of this enzyme, and what it does is it breaks down alcohol. So the alcohol comes into the stomach, but there's less of this in a woman's stomach to help break down the alcohol, so more intact alcohol, if you will, gets into the bloodstream, therefore elevating the blood alcohol concentration. Liver alcohol dehydrogenase, the same thing. Females have less active form of this enzyme and therefore do not metabolize alcohol as efficiently as males. So one drink in a male may be the equivalent, and is the equivalent for many women, of about 2 drinks. So these are pretty significant things that people who study this are really focusing on in terms of trying to understand it better. So pivoting to our older adults, alcohol affects behavior and health differently as we age. Health consequences of alcohol tend to shift from acute causes like injuries, accidents, to chronic causes like cancer and heart disease. And this occurs with age and alcohol use. So older adults, they're more sensitive to the sedative effects of alcohol, as well as their reaction times are impaired, balance is affected, and attention and driving skills are more affected as you age, partly because they experience reductions in body weight and body water, which leads to higher blood alcohol concentration. He's used to having one martini, and now one martini really makes him drunk versus just a light buzz 20 years ago when he was in his 40s. Take more medications that may interact with alcohol. So older adults typically are on more medications, and some of these will interfere with the breakdown of alcohol and cause higher blood alcohol concentrations. There's an increased risk of injury, and also the fallout from those injuries, the falls, can lead to more serious consequences like broken hips and things like that. But both alcohol and aging are involved in widespread inflammation, and they also contribute to cardiovascular disease and can disrupt sleep. And then moving on from adults, let's talk a little bit about alcohol and the COVID-19 pandemic before we get into treatment. So we're still feeling the effects of the pandemic when it comes to alcohol. 1/4 of the population in the US increased drinking during the pandemic. Women were more likely to increase drinking than males. Greater increases in quantity of alcohol consumption among Black and non-white participants. And individuals who increased their drinking were more likely to drink to cope with stress. So increases in alcohol-related harms during the COVID-19 pandemic. An increase in the percentage of emergency department visits that involve acute excessive alcohol consumption were noted. An increase in the incidence of alcohol withdrawal in hospitalized patients. So what this is referring to is that when somebody gets, let's say, an elective surgery or needs to be hospitalized for an unrelated reason, in the history, the doctor, nurses, so forth, are taking the history and they'll say, oh, yeah, I have a beer, maybe 2 at lunch, and sometimes I have 1 or 2 at dinner, and that usually gets passed on. And so then they have their procedure or their surgery, or they're getting fixed for what have you. And a day or 2 goes by and surgery calls us, or calls medicine or addiction, and say, like, I don't understand what's going on. I fixed his hip, but he's really hypertensive, he's sweating, his heart rate's, crazy, and I'm sure it's not an infection because we don't see any other sign. Sure enough, he's in withdrawal. And so we go back and we get that history, and it turns out, well, people tend to minimize their alcohol use. So we ask his wife, well, it's not really 1 or 2 for lunch. Sometimes it's 2 or 3. And then again, it's another 2 or 3. So he's used to having 6 beers a day. And now he hasn't had anything in 2 or 3 days. And he's starting to feel the significant withdrawal. Now, withdrawal can be very, very serious. For some substances, maybe cocaine or heroin, it's not going to kill you. It's going to make you feel really uncomfortable. But alcohol withdrawal can kill you. That is a very serious thing when somebody can have seizures from alcohol withdrawal, or it can lead to something called delirium tremens, where they can hallucinate. And if it's not taken care of and dealt with, there can be upwards of 2 to even 8% death rate from alcohol withdrawal. So our counselors at Wellmore are trained, and we look for people who are coming in. If they're in withdrawal, what is the substance? And if we're at all concerned about that being alcohol, we quickly try to get them into detoxification or even to the emergency room if it's happening acutely. So also, increase in deaths from alcohol related to liver disease. That was bigger than prior years. This happened in the pandemic. And then, as we said earlier, 14% increase in alcohol-impaired driving fatalities. So let me just pivot and just talk for a little bit about treatment. Alcohol use disorder, these are FDA-approved medications for treatment. And the tragedy here is that these have been around a while and they're not being prescribed as much as they should be. All of them have shown benefit, and they show moderate to good impact on any kind of alcohol use. So that's really important to know, and it's kind of like we're withholding treatment if people are not at least given their options about what the risk-benefit balance is for each one of these medicines to their situation. So naltrexone has been FDA approved since 1994, and then the long-acting naltrexone, you may have heard of something called Vivitrol, which I thought was FDA approved like 10 years ago, and it's really been closer to 20 years. And this decreases binge drinking. There's good data to show this, and the FDA has approved this to help with decreased binge drinking. Acamprosate has been around since 2004, and this is a good medicine that once someone has stopped drinking to help them maintain their abstinence. Disulfiram has been around since 1949. It was FDA approved, and that is, with good clinical supervision, can help improve adherence to non-drinking. Nalmefene is a substance, a medicine that's being used in Europe now, which is not FDA approved in the US. I think this is a bit more about alcohol use diagnosis, and Regan may go there for a bit. And then the last thing I'll leave you with before I turn things over to Regan is just to put forward the psychosocial interventions. You'll see there's several here. You may recognize a few of them: cognitive behavioral therapy, 12-step facilitation, contingency management is one where vouchers are used and shows enormous benefit for people who have issues with cocaine use disorder. But all of these are very good for substance use disorder. But one of the things that we stress so much is it's not how fancy the medicine I prescribe is or what therapy Regan's clinicians can put together for and how elegant that therapy may be, but it's all about engagement, 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 because all of these treatments work. They're all beneficial to individuals, whether it's medicine, whether it's therapy, whether it's both. But if nobody's showing up to take the medicine or to join the group, they're not going to get any benefit. And this is a really big deal because there's been a huge movement over the last decade or more from abstinence only to abstinence as a tremendous goal, and it should be a goal for everyone. However, it shouldn't be the only goal. And so there's something referred to as harm reduction. And this is really important because we want to get people to be involved and be engaged in their recovery and take ownership of their recovery and feel empowered to improve their morbidity. And so just to give you an example, if somebody is used to drinking 4 drinks a day and they can reduce that to if somebody's used to drinking, what did I say, 8 drinks a day, and they can reduce that to 4, that will dramatically, literally half their morbidity and reduce their chances of these cardiomyopathies and these brain atrophy and all these liver disease issues and so forth. So it's really important to reduce abstinence. Credible goal, we need to strive for it for everyone, but not the only goal. So with that, I will turn things over to Regan. And Regan, do you want me to do the slides here? Or do you pick them?
I can do it. I can take over and
okay,
take
perfect.
over the slideshow from here.
All right, thank you so much.
Thank you. Hopefully you can see my slides. Dr. Aaron, can you see it? Okay, great. All right, thank you. So yeah, so taking over, talking a little bit about treatment, I am going to go back a little bit and talk about what makes an alcohol use disorder. And why I think it's so important is because things I hear, is when people are saying, oh, I don't drink every night, or, I only drink a couple times a week. One of the things that we look at when diagnosing a substance use disorder is not so much how much you're drinking, how it's impacting you physically, but also impacting or impairing your other areas of your life. So as Dr. Young said, it really only takes 2 of these 11 criteria, and I copied and pasted this right from the DSM. The language is exactly the same. So something like a great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effects. So having a hangover, something like that. Recurring concerns with, fulfilling major roles. So as a mother, as a wife, as a, your person, what you do for your employment, school, work, or home. So when we're looking at saying that somebody meets the criteria for treatment, it only takes 2 of these 11 criteria to have you diagnosed as having a substance use concern or alcohol use disorder, or being at risk for it. So even if you have 1 or you're at risk of developing 1, you could qualify for formal treatment for substance use disorder. So just as we go through this, thinking, of who could maybe benefit from treatment or that formal support. So the treatment that we do, sorry, the next screen is a little slow, but going over the screen that Dr. Young had on the different types of therapy for substance use disorder. Sorry, my screen is not working. There we go. So some of the things like motivational interviewing or cognitive behavioral therapy, these are types of therapies that we use in either individual or group treatment, not only at Wellmore, but other substance use providers as well. Having peer support still extremely, extremely important. So we saw when NA was developed, we also have NA and other peer support programs that are extremely helpful for people, either alongside of formal treatment or as an aftercare, or people do that as their treatment and report huge success. So programs like Smart Recovery. There's also a women-specific peer support group, Women for Sobriety, and then also Al-Anon. Al-Anon is a wonderful peer support for individuals that have family members that are struggling with addiction. And family term is used very loosely. So it could be your significant other, it could be your child, it could be a friend that you're very close with, somebody that's very important in your life. So it's a great support for somebody that is dealing with someone else struggling with substance use disorder, alcohol use disorder. Wonderful things about all these now from the pandemic, everybody has virtual options. So you can log on to AA, NA meetings virtually. Smart Recovery, always very engaged in social media and virtual platforms, but Women for Sobriety and Al-Anon as well. So you can log on from home, log on from your phone in your car, whenever it's convenient for you, and when you're able to engage in services. So Connecticut over the past few years has really done a huge push to really change the way that we're doing treatment in all of Connecticut. So initiated by DEMIS, looking at the models that we're using for substance use treatment. So now all of our substance use providers are really using a manual called ACAM, or the treatment criteria for addictive substance and co-occurring conditions. And what that does is it looks at the whole person. So in the past, we would say, okay, you have an alcohol use disorder, we're going to send you here to treat that, and we're going to treat your depression over here, and we're going to treat your medical concerns over with your primary care. Now we're really trying to treat the whole person altogether. So holistic care and multidimensional care. So looking at physical, their recovering environment, looking at their risk for continued use or problem behavior, and then their mental health or any cognitive concerns, and treating the person as a whole. Another thing that we're really moving towards is from program-driven to treatment to clinically driven treatment. So looking at that person individually. So now, in the past we would say, okay, you come to IOP for 5 weeks, and then you step down to an outpatient for 10 weeks. Now, we're really looking at individually, what does that person need and what is that person benefiting from? Working with the person individually, not only to assess their unique goals, but also to look at the barriers that they have in treatment. So, recommending a mom who has 3 kids at home and no childcare to come 9 hours a week is unrealistic. So, at this point, we're really looking at individually, what can that person do to help engage in their recovery. Another piece of that, as Dr. Young mentioned, is harm reduction. So before it would be, your urine drug screens, making sure they're negative, making sure that, again, you attend your sessions. Now it's really looking at what are they reporting? How are they feeling? How are those relationships in their life improving, or their work ability improving? So looking at individually how that person's doing. And that a lot of times is harm reduction versus staying sober, completely for their whole lives, which is an extremely difficult goal to achieve. The continuum of care. So this was important because a lot of the language I hear in the community or in my personal life is, somebody that's struggling with a substance use disorder should go to rehab, or they need to go to a 28-day program. Really now, when we're looking at someone and recommending treatment, we look at what we call the continuum of care. So we have early intervention, which could be that at risk of developing a substance use, could be 1 or 2 times a week, coming in education and support from a therapist, to our highest, which is medically managed. So that's where you'll see some of the detox, or we call now withdrawal management programs, when somebody needs medical care alongside their treatment to help them stop using. We at Wellmore fall right in the middle. So we're in the intensive outpatient or outpatient or 3.5 residential level of care. So when looking at the continuum of care, you do have a lot of options as a client. And again, we look at, the barriers as well too. So recommending somebody go to an inpatient facility when they can't leave their job. They can't leave, they don't have anyone to leave their children with. What we would do then is help them at a lower level of care and maybe help them connect to some of the AA community or engage in, some of our peer support, on site as well. One of the things that Dr. Young talked about is engagement. Engagement is so important because it's great to come in, again, 9 hours a week for treatment, but what else is going on outside of your work, and then of the work inside Wellmore, but then also are they coming to treatment? So one of the things our field is really working towards is hiring recovery coaches or certified peer specialists. So people that have lived experience in addiction that identify as being in recovery. And it's a certification program, a wonderful certification program. And we hire now, many substance use providers across the state hire as part of our multidisciplinary team. So recovery coaches that are working with our medical team, with our clinicians, with our case manager to try and connect people in a different way. Having that lived experience, being able to relate in a different way. We've seen huge success with, and it's been a wonderful addition to our team, not only learning, from them, but also that engagement piece as well. And then to talk a little bit more about the treatment at Wellmore, we could go into all the different programs that we have and how we help people, but what we tell people all the time in the community and they call, just come in. So we do full open access Monday through Friday, 11 to 3. We do have a licensed clinician and our peer recovery specialists and case managers that are on call during that time. The one thing that's so difficult about our system, our behavioral health system, is that it's so difficult to navigate when you don't know the terminology, when you don't know what levels of care mean, or you don't know what the person needs, if they need medical intervention. We receive so many phone calls where it's, how do I have an intervention with this person, or how do I get them into treatment? What we always say is come in and let's have a face-to-face conversation. So we can assess them, we could figure out what they need, try and encourage them and motivate them to engage in that level of care, whatever it might be, and connect them. So it could be even driving them to where they need to go if it's not with us in treatment. So if you do have anybody that is struggling and is open to even just talk to someone, we open that up to the community, 5 days a week, like I said. So you can always come in and learn more about it, or learn about the treatment options, how you can help somebody in your family or somebody that's close to you, or you yourself. All right, so I don't know, Jared, if we want to open it up for questions at this point. We have about 10 minutes left.
Yep, let me see if I can get everybody to, folks are able to pop questions inside the chat, and then I'll also work on trying to get everybody access if they'd like to share some questions as well.
Okay. See, people are typing now.
So we're able to update the permissions. So if anybody would like to go on camera and or ask questions, feel free to do so. So it looks like Logan has a question. Can you speak at all on the genetic predisposition to alcoholism?
Yeah, I can talk a little bit to that. That's a great question because it does seem like there are a variety of components that make up whether or not someone is going to develop a substance use disorder, or specifically in this situation, alcohol use disorder. And clearly, one of them is exposure. So if you've never been exposed to alcohol, then it likely won't happen, obviously. But exposure is one, and stress and adversity throughout life is another that helps kind of accelerate it. There's certain, we didn't get into it in this talk, but certainly what we see a lot of is co-occurring, that sort of braiding between mental health and substance use services. And so people who have mental health diagnoses are much more vulnerable to developing substance use disorders, alcohol namely one of them, and individuals with alcohol use disorder are much more vulnerable to developing mental health issues like anxiety and depression. So the genetics is a huge component to this, and that from that first slide, you saw the first kind of discussions about that with Dr. Jelinek in the gamma subtype of this excessive. And there's been some study on this and identification of individuals who are more vulnerable to alcohol use in sort of binge and excessive drinking. And so there are some genetic subtyping of this, and that's certainly a vulnerability. If it runs in a family, that's certainly something to be really proactive and careful of. I remember seeing I was at a conference a couple of years ago, and I ended up sitting next to a woman addiction psychiatrist from Minnesota, and she actually was a Native American, and she was there largely because that alcohol has really devastated that Native American populations, and that was something that she was talking a lot about, that sort of genetic propensity for substance use and excessive use. And so I can't get real into the detail on the different subtypes and the genetic subtypes, but certainly I think that's a very fair question about predisposition, and is certainly many of us have that, and it runs in our families.
Amy has a question on, is there any specific time of year when some of these alcohol deaths occur?
Yeah, that's a good question. I think what you'll see is, I don't know kind of a formal answer to that. If I talk to my ER docs and my orthopedic friends, they will tell you the summer is a rough time for injuries, and people are more out and about and more disinhibited, if you will. But that's not, I don't have data on that, but I think that's a great question. I just have sort of ad hoc stuff from my colleagues in other aspects of medicine, like the emergency room and orthopedics, but thank you for that question.
I can say too, we see a spike in treatment, which a lot of times people come to treatment when there are consequences. So, that for all of us, we change our behavior when there's consequences, or we think about changing our behavior when there's consequences. And we see a spike around the holidays. So around Christmas, Thanksgiving, we see a spike of people coming into treatment, and then in the summer as well. So we do see usually an influx in the spring, when the weather does get nicer. We tend to get busier as well. So those are our two big times for people to come into treatment.
Then you have your hand up.
Yes. Oh,
Yep, you're on.
yeah, the camera's here, the video's there. So I don't know if this is an impression, I'm getting a misimpression. Does this path toward health, does it depend on the person with the alcohol problem admitting that and seeking help? What about those who don't admit it, and who are when families, the kids have to deal with it, the parent doesn't admit it, etc. What is it? Can you do anything for those families and children?
Yeah. So it becomes very difficult, just like I said before, when you have a behavior that other people see as benefiting from change, but you don't see that benefit or are open to looking into changing that behavior. That's where I think Al-Anon is a wonderful support for families. It's a group of people that are in similar situations or have been in similar situations that can share interventions that have worked for them. And then also therapy for the family members as well too. So, individual or group therapy, more formalized treatment to help with, some of the things that come along with living with or being in a relationship with or having a parent that's struggling with substance use disorder. So things like setting boundaries, things like self-care, things about, looking at what role you may have in that concern or that problem. I think is very important.
Yeah, I would just like to add, I think that is a really good point to bring up, is that what we have found over the years is that we really have to meet people where they're at. And instead of sort of the kind of older school way of like, this is our treatment, this is what we do, and if you have a positive urine or a relapse, then you're not welcome here anymore. And that is just not effective and alienates a lot of people from treatment. So some people are all the way in, some, I just want to hear a little bit more, I don't really think I have a problem, but finding them where they are and where their family is can be a really helpful to those first steps of engagement, where they're building trust and we're not just clinicians out to judge them.
Mm-hmm.
Looks like we have one final question, Tammy. One of her question around substance use disorder on folks that are literally street homeless or might be homeless living in shelter. And I would, if we can maybe focus a little bit more on some of the challenges and barriers around folks who are unsheltered. So the folks might be living outside, and the implications, I think, folks that are in shelter could be a little bit more managed and supported, as opposed to folks that are literally street homeless living outside in abandoned buildings and bridges.
Yeah. Yeah. And it's so difficult. It's such a huge question, a huge topic, because it's only a piece of what the person's struggling with. So their alcohol use disorder or substance use disorder is only a piece of that. So we can do wonderful work in treatment, but then they're going back, to live on the street or live, wherever it was that, where they've been staying. So one of the things that we try really hard at Wellmore to do is to connect with case managers. One of the nice things about, having a multidisciplinary team is that we have people that are assigned just to work with the other psychosocial stressors that are going on with the person. So case managers, we also utilize some of our recovery coaches for that too, to help with some of the other needs that, the individual may have. And like Jared said, I think it's a little bit different if they are, living in the shelter, because we collaborate and, work with the staff and case managers there, but very difficult when the person is living on the street. We do have some housing. There is some recovery housing in the state, not enough. But we do have our program, which is called Morris House, Morris Recovery House down by the police station, which will be opening in about 2-3 weeks. We were closed for a little bit. So that's a wonderful option for people. But again, there's not enough in the state to help all those that need it. But I don't know how anything else to add to that in the few minutes that we have. Dr. Ham.
No, I would just sort of echo that, the whole component, why I really enjoy. I've been at Wellmore 18 years, and it's the multidisciplinary. It's like, yeah, I know a fair amount about the medicines, but we have clinicians that are really good at the therapy, and then we have case managers that know what's going down on the street and what the situation really is like in terms of being unhoused or not. And I think that when we come together, we round pretty regularly. Everyone has something to contribute, and to me, that's why I got into this. Is I think that is the best comprehensive way to give quality care, is when we know all of those components. And so it is a huge issue, and that's going to be case management heavy for that, to help with the housing situation and get them engaged in the medical care. I don't know if we have a program called PIC, which is about getting people who are approaching us with substance use issues, and because of that, they have neglected their health care. They may have poor problems with their teeth or their lungs or liver and stuff, and they just never get the care. And right across the hall, we have primary care individuals who can see them. So once they may come to see us for their alcohol use or their depression, we can quickly get them shoot into the medical team to get them their blood pressure dealt with, their diabetes dealt with, things like that.
I want to thank everybody for participating, especially Dr. Young and Regan Moriarty for the great work that you guys do. And we're really excited to continue to partner with Wellmore. United Way is committed to standing shoulder to shoulder with the great offerings that you guys provide to our community. We are most grateful. And really grateful for the day in and day out work that you guys do each day, right? The reality is you guys are unsung heroes in our community, literally saving lives every day, and have been so impactful to so many different people that we could never even imagine. So on behalf of the team at the United Way of Waterbury, please know that we are most grateful for the service you provide to our community, and know that we're always with you. So thank you so much. We appreciate your expertise and your support.
Thank you for having me.
You guys too. Take care. Thank you.
Thank you.